Hi, my name is WynneCallon. I'm a medical student here at Johns Hopkins. I'm taking a year off to do research between my third and fourth year of medical school. And I've been working on healthcare communication, so communication between doctors and patients in clinical encounters, and this is some of the work that I've done. So today I'll be talking about a project I did in which I looked at what types of questions by clinicians, doctors, nurses elicit accurate disclosure of antiretroviral non-adherence when talking to patients. So these are encounters with HIV patients, and we're talking about their HIV medications and whether or not they're taking their medications. So just as an introduction, very few studies have looked at how best to assess for medication adherence in the clinical setting. So some previous studies, one in 1990, so a couple decades ago, found that open-ended, non-accusatory, and information-intensive approaches were most effective at eliciting disclosure of non-adherence from patients. Another study in 2006 found, again, that open-ended questioning, collaborative style, and use of lay language were most effective at helping patients feel comfortable in order to have them disclose non-adherence. So in the HIV setting, there's extensive literature looking at how to assess antiretroviral adherence on written questionnaires, but not a whole lot on how best to do it when talking with patients in real life. So the aims of this study were to look at how providers actually ask about antiretroviral ARV medication adherence in the clinical setting, and then two, to determine the types of questions that elicit higher rates of accurate patient disclosure of this information. So our sample came from a larger parent study called the Enhancing Communication and HIV Outcomes Study, which had 434 patients and 45 providers in 4 sites. So Baltimore, New York, Portland, and Detroit, all cities in the United States. And our sample included all patients who reported non-adherence in a 3-day recall assessment conducted by a research assistant. So these are patients who said that they had missed a dose of their medication in the past 3 days. And in total, we had 58 patients and 34 providers. So all of the information, all of these encounters were audio recorded. And what we did was we transcribed those audio encounters and then looked at those transcriptions to do our analysis. So first, we found all of the dialogue in the transcripts that was related to the HIV medications, and then identified all the questions that providers used to ask about adherence. And then we did what's called a conversation analysis. So we inductively generated categories. We looked at all of the questions, and without going in with any preconceived kind of categories, we developed our own categories of questions that we found in the dialogue. And then from there, we looked at the relative risk of accurate patient disclosure by question type, adjusting for a couple of factors that you see there. So this was our sample. We started out with those 58 visits with patients who had said that they had been non-adherent in the past 3 days. We excluded from our analysis patients who disclosed non-adherence unprompted by the provider, so they just said without the provider asking any questions that they had been non-adherent. And then there were a couple of instances, 8, in which the clinician already knew about non-adherence. So these were instances in which the patient had recently been hospitalized and this information was already known, or they had been off their medications for some time for another reason. So from there, we had 3 categories. So one was the patient disclosed non-adherence after the clinician asked, and that was 32 cases. There are 6 cases in which the patient did not disclose non-adherence after the clinician asked, and then there were 4 cases in which the clinician did not ask about the HIV medications at all. So the questions that we discovered through our analysis we found 4 categories: broad, clarifying, positively framed, and negatively framed. And these are examples from the dialogue of each of those. So broad questions are questions like, how have you been doing on taking your medications? These are questions that don't have a yes/no answer. Clarifying questions, which are kind of medication reconciliation questions. So are you still taking the Conbivir, Varian, and Sestiva? Are you on the same medicines now, or did you change any of them since then? And then positively framed questions. Do you take your HIV medicines every day? So these questions all had the verb taking in them, whereas negatively framed questions had the verb missing in them. Have you missed any doses in the last 4 weeks? Do you miss your medications sometimes? And what we found was that disclosure rates were much higher in the negatively framed questions, the questions that said, have you missed any medications? Whereas disclosure rates in the other categories were much lower than that. In addition, we found some secondary categories. Our numbers weren't big enough to look at these in depth, but what we found were there were some questions that were leading towards adherence. So these were leading patients to say, yes, I've been taking all my medications. So you've been taking your HIV medications, right? You haven't been missing any of the medicines, right? So these kind of push the patient towards saying, yeah, I've been taking all of my meds. And then normalizing non-adherence. So these are questions that go a step further and make it seem even kind of more acceptable to miss medications. So when was the last time you completely missed a dose? How many doses have you missed? So these asked about the last time or the quantity of missed doses. And then in multivariate analysis, where we adjusted for the order in which the questions came in the dialogue, so many times providers asked many different questions about the medications, and then whether the question was leading or not, we found here that the question order mattered in the unadjusted analysis, but in the adjusted analysis, the question order no longer mattered. So when we adjusted for the types of questions being asked, that no longer was a factor. Whereas negatively framed questions continued to be the most effective in our analysis at eliciting disclosure. So why do we think that the negatively framed questions are more effective? So first, missed, we think may be more specific. The provider's intent is clear when they use missed, whereas taking regularly requires interpretation of what regularly means and things like that. And then missed is also somewhat normalizing. So again, this kind of gives the patient permission to disclose and decreases the barrier to disclosure for them by kind of making it seem okay for them to be missing. And then broad questions aren't quite as effective, we think, because they're very non-specific. It's really unclear what the provider is asking. How's it going with your medications could mean anything from were you able to pick them up from the pharmacy to are you having any side effects? And then clarifying questions seem to be asked with the goal of medication reconciliation, and so the aim doesn't seem to be to assess adherence, and therefore the patient doesn't answer in a way that discloses their adherence status. So a couple limitations of this project. Our sample size was not big enough, as I mentioned, to assess the effect of normalizing and leading questions, our secondary categories. And in addition, this was our sample was limited to patients who admitted non-adherence on the 3-day recall. So we did not have patients, so there may be patients in our sample who did not disclose non-adherence to our research assistant either. But what that means is our sample had patients who were more likely to disclose their non-adherence status, most likely. And then finally, recording encounters may affect patient and/or provider behavior. But we would expect the provider behavior to be probably better in terms of providers would be more aware of asking about this information. So we believe our findings are conservative in that sense. So in conclusion, we found that a substantial minority of providers did not elicit disclosure of non-adherence in our sample. Broad, clarifying, and positively framed questions did not seem sufficient to elicit accurate disclosure of this information, and asking directly about missed doses increased the likelihood of accurate disclosure of non-adherence from patients. So I'd like to acknowledge the co-authors on this project, and happy to take any questions.